name's Nick Culbertson. I'm a fellow with the Institute of Critical Infrastructure and Technology, and I'm a co-founder to a startup called Protenus, which does data analytics and specializes in health data security. So we're talking about HIPAA violations is the last talk of the day. For those who know what HIPAA violations is, you're probably thinking, why the fuck are we talking about HIPAA violations at the end of the day? For those who don't know what it is, I just ask you bear with me, because my goal is to get at least 10 people to rub their chin and say, this is really interesting, because what we're talking about is a very serious problem, but one that's very often ignored by the general community. So the challenge is that virtually every health system has unfettered access for their employees to access patient data. So think about that for a second. If you're in finance or in your intelligence or social media, you're gonna have some kind of limit on who's supposed to access data and who's not. But in healthcare, if I'm an ER doctor or a nurse or a billing or a coding or a medical student or whatever, I have the same access to every amount of information in your medical record: billing, financial, medical history, your prescriptions, your allergies, all of it. And so, sure, the hospital system is generating millions and millions of access logs every single day about that type of behavior and monitoring that, but how are you supposed to go in and say, okay, this person was doing their job and this person was not? So that is an incredibly challenging task. And for those who don't know, when you access a medical record that you're not supposed to, that is known as a HIPAA violation. So it is a federally regulated industry standard that dictates that you're only supposed to access patient data according to the care that you're providing with them. And if not, you can be fined, or the hospital can be fined, up to millions and millions of dollars, not to mention the legal ramifications and the reputational damage that happens when a hospital has a big breach like this. So it's a big problem. So I'm gonna stop there and just give you a bit of background on myself. So I served 8 years in the military as a Green Beret, and I did human intelligence networking gathering overseas. Basically did the opposite of everything we've heard about today in terms of big data. I worked with extremely small data, very limited information sets, and tried to make actionable intelligence out of that. I then switched into academia and worked as a biologist and did synthetic biology and cellular molecular informatics. Completely different world, and got introduced to this. Started out at med school and realized, wait a minute, I can just look up any celebrity inside this medical record system and no one knows anything about that. So one thing led to another, realized there was a big problem, and started going after it. So we hear about only the tip of the iceberg. I'm sure you guys have seen in the news. I knew that was gonna happen. We see in the news, ex-celebrity breached in the hospital. But the sad thing is, what you hear in the news is only a fraction of what the hospital knows about, and what the hospital knows about is only the tip of the iceberg. And this is exactly what our analytics are finding, is the problem is much more pervasive than any of us actually realize. So how do hospitals deal with this now? What they actually do is they have somebody in an office waiting by the phone for a call from the FBI or from a patient who says, hey, I think my privacy was breached. And they say, okay, hang on 1 second, let me find out. I'll get back to you in like 6 weeks. And then they go and they pull access logs to the medical record, and they pull HR data, and then they pull the clinical data, and they start to put together this big picture about, well, maybe someone looked at your record inappropriately, but I can't really tell. So that whole process can take up to 6 months to actually identifying when something happens to then actually remediating and closing those damages. So again, huge problem that is just not being addressed right now. So this is the reason it's so challenging. Medical records, I'm sorry this is so small, but there's really nothing to see here. Rows and rows and rows that say this person accessed this patient at this time, and this is what they did, and this is the part of the record. Incredibly detailed story, but how do you actually understand, okay, is this one row different than another? And I don't want to get too much into the theory behind anomaly detection or multivariate anomaly detection. I want to try to break this down to simple things that I think make sense in terms of biology and talk about how we actually figured this out. So how many people know how molecular biology works? Awesome. For those who don't, this is going to be a really quick primer. All right, so long time ago, a guy named Watson and Crick figured out the genetic code. The idea that how this works is you have a sequence of DNA, A, C, T, G, whatever, goes on forever. The problem is they knew that there was a sequence to that must provide some type of information. But the thing they were missing, the thing that they finally figured out that broke the whole code open, is the idea of a start and a stop codon. So you have this long row of information, and then you have a key that says, start here. Here's the behavior that you need to identify moving forward. And it's the same thing in a medical record. You can imagine, especially on a really old-fashioned thick client or something, when you go into a medical record or a website or whatever it is behavior you're studying, you only have a limited number of options. So think of it as a decision tree. Like, I open the record, I log on, I enter my password, then I can access a patient's record. I can do a search, and from there I can go into 9 different modules, and each module I can click on another thing. So there's only an option, different types of array that I can actually get to inside the medical record. So this is an example of that. You can see here there's a long sequence, but unless you know where to start, the secret of where you start is up there at the ATG. That is what then starts to interpret the code into a protein sequence, turns into protein molecules, and then builds the rest of life as we know it. So what this led us to do is actually start looking at the access logs like a DNA sequence. And what we identified were, what are the keys to getting inside the medical record and that baseline behavior to track everything from that. And so we did an n-gram modeling to actually identify what is the probability of starting from one place in the medical record to go to another. And then we actually modeled out what are the typical behaviors that people have based on their role. And this is what it looks like. It looks like a pretty little weave. And what you're looking at is basically the first 6 steps from entering a medical record. And you think about the entire universe of healthcare and all the different things you can do simplified into one visualization about the different options that you can do once you go into a medical record and click through the process. Okay, so this is a lot of noise, big data problem, so much information. What do we do with it? Now we simplify it by the different types of roles. So think about a researcher who's doing chart reviews and going into the medical record and pulling out information. What they're doing is that behavior is going to be very consistent over time. Compare that to a clinician or a ward nurse who might be treating one type of patient in the morning, someone very different in the afternoon. Based on the type of the procedure they're doing, they're going to have very varied behavior throughout the day. But you can still limit that to certain type of behavior patterns over time. And so what we do is we actually analyze, I'm sorry, this is small, it's not fit to the screen well, but what we can do is actually model how these employees access behaviors through the day, how they behave inside the medical record, and then how they behave between medical records as they pass them virtually from one employee to another around patient care. So the next step of this, going back to biology, this is a bit of an abstraction, but there's this idea of a hydropathy plot. So the idea of a hydropathy plot is you look at a sequence of proteins now. So we took our DNA sequence, we made a protein strand. Every single protein has a little type of chemistry element to the end of it that gives it a different behavior. And this is not looking at one single behavior, but this is looking when a couple of clusters of behavior comes together to be abnormal. And in this case, it's hydrophilicity, which actually makes the protein molecule form up into a little ball. What we're looking at is, and this is generated just using Tableau, you can see that the different behaviors over time tend to seem consistent, but then all of a sudden you have a very unprobable entry into a certain aspect of the medical record that makes absolutely no sense. And so we're doing the exact same thing, identifying over time. And so I'm going to display this in a different way and see if this makes more sense. So this is an employee's behavior over a single day accessing an array of medical records. And the colors represent the behavior inside the medical record. So in the beginning, an employee opens up the medical record and looks at, let me think about this. So looks at the demographics, which would be in purple, and then goes into the appointments, which is red and yellow, and then looks at clinical data, which is in green. And then all of a sudden, towards the middle of the day, you can see all of a sudden they search for a patient by name, which they never do. And then they skip over the appointments and go right into the clinical data and spend a lot of time in there, which they never do. And so now you have this deviation in behavior based off of not just one thing, but an array of things that comes together that actually identifies as suspicious. So I'm going to wrap it up there and see if there's any questions.
Just really quick, when you showed that
So that was, so they were ordered by time and record. It wasn't sequential, but it was all real data.
So what would that case mean? That one time where it was a direct, like I search for a user and I just spend most of the time on the person's history. So that you showed us that was user case and that person who was looking up information had that one thing that stood out. Like what would that mean?
So there's a lot of different types of privacy violations, and that's how we bucket into this bins. It could be something as benign as the person going in and snooping, or often, and I think what that case actually was a celebrity where they were sitting there and Snapchatting the patient's medical record and taking a long time and going through all the different pieces and saying, hey, this person's on this narcotic and blah, 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 blah. So even though we are not detecting the person sitting there with their iPhone and taking a picture, the behavior is obvious enough that it doesn't look normal. Yes?
Are the EMR logs that you're accessing HIPAA protected as well? Like, do you as an organization need to worry about breaches? Or
Yeah.
Okay.
Great question. So we actually take our access logs up to the top and dump it into the top as well. So we actually have detected privacy officers breaching privacy using our tool in return. So yes, who watches the watchers? Is that your question?
Yeah, what do you do in that case? Do you fire a client?
So we actually, there's a lot of technicality around HIPAA rules. We actually don't use the platform to monitor their records. They use it, and then so they would get the alert on themselves and then use that alert to fire themselves.
So you. So the platform runs like on-prem. It's not. You don't need to worry about like transmitting records off-site.
No, so we actually do. I was talking with a couple of people about this. So we can't use a lot of these really fun tools because everything that we do from a data architecture standpoint has to be encrypted, end-to-end, non-accessible to the public, and secured down beyond reason many times. Yes? If we were using Epic and where we would plug it in, so if we were doing it in real time, if we're getting really technical, Chronicles, and if we're doing it not real time, Clarity. Does that answer your question?
So would you take the data out of Epic to plug this in, or you use it on top of it?
So we actually create big data lakes that involve not just information from medical records, but we're bringing in HR data, we would bring in medical record data, we'd bring in card swipe data, we're bringing in like IRB research data. So it all comes down into one big data lake that then we build the infrastructure to create the patterns over time. Does that answer your question? I want to make sure. Yeah. Yeah, so we have the same problem, I like to think, as the CIA, that we really can't brag about our successes. But so far, no one has heard, or we've never had a really big event that's made us look bad. I can tell you we've caught everything from like, people snooping on their family members, the fantasy football players looking at their athletes, to just the snoopy celebrities, to people who are repeatedly watching the news and looking at patient records, to people who are stealing medical records and selling them for personal gain, to people who are downloading massive records. What's funny is that a lot of the privacy violations we detect are not just privacy violations, but also prescription fraud, identity fraud, theft. So it's kind of the mad spectrum. It's like fewer of the worst stuff, a lot more of just, oh, I know them, that's my neighbor, or that's my girlfriend, I'm going to see if she has an STD and then dump her. You mean like a role-based access control? So there are ways to do certain types of role-based controls, like creating provisions on what kind of data you access. The challenge with that is you get then a lot of end users who say, I need access to this information. You wouldn't think that the person who brings the meal trays to patients in the ward needs to look at your charts and your prescriptions, but they do because they have a little list that says if they're allergic to this, you can't give them food, so they need to go in, and then they need to write and say how much water the patient drank from their tray when they take it away. So you create this environment where you want to limit people as much as they can, but at the same time, the more you limit them, the more you're preventing the patient from really getting good care. And the day that a physician is blocked out to get critical information about the prescription a drug had that has an interaction, they end up killing them, is the day you rip out all of those role-based access controls. So that's why healthcare has this problem that no one else has at this point.
So I'm curious how you deal with false positives. So if your system detects something as a violation, but then it really actually isn't.
Yeah, so any good statistical approach, we are optimizing for specificity instead of sensitivity. So we can't necessarily guarantee we're finding anything, but we can guarantee the ones that we are finding are the most suspicious and the most risk-pervased in the data set we're finding. The other thing is when we first turned this on, we increased the number of privacy alerts that an organization gets by like 16,000%, easy. Like standing by the phone compared to getting proactive alerts on a daily basis, they can't even handle the number of cases they get. So we actually create controls that just pick the worst ones off the top and gives them as many as they can handle over a period of time. So it's a tricky challenge, but because we can optimize for specificity, then we don't actually have a bad false positive rate at all. In fact, sometimes we have up to like 97% accuracy rate. It's a great question, though.
Hi, I work as a web designer, a web programmer and designer, and a lot of times, have you guys thought of implementing what we do with currency to protect people's privacy? Like, there's a double-blind encryption where I can have a code that the machine knows who the person is and whose card it is, but the end user can't steal because the data is encrypted on one side. So have you guys thought of a way where if I'm just a receptionist and I need to look up someone's medical record, I can process that person in a way where I don't know who I'm processing, or I don't see all of their data. Maybe I just get a name, but the machine adds the data, and everything is still kept in the database for the doctor.
So 3 things. 1, I don't think I know enough about that to answer intelligently. 2, I have heard of blockchain style of medical records that I think is somewhat similar to what you're describing that could actually address this problem really well, although it goes back to somewhat of the role-based access challenges. And 3, and probably the biggest problem is, when you're dealing with financial data, when you're dealing with social media, with ad tech, we're using cutting edge technologies. We're using Spark. We're using that awesome tool we just saw. Really fast, really great. Healthcare has been forced into the electronic world over the past few years and is literally 10, 20 years behind other industries. So to create systems like that and implement that, we have a hard time just getting medical records to be able to talk to each other at this point. And so unfortunately, tools like this or solutions like this don't always work. But honestly, to go back to my first point, I don't know if I know enough about that to answer your question directly.
Do you brief the employee population on how they're being monitored? And if they saw a report like this, would they change their behaviors to not send the signal?
So it depends. It's up to our customers. Sometimes they like to keep this secret and they don't tell them that they're doing it because it's a policy anyway. You're not supposed to do this. Sometimes it's actually part of an initiative and they say, here, we're using this tool. We're going to increase training. But the big benefit of this is actually after you use it a while, you actually see what types of employees are more likely to breach privacy, what types of departments are more vulnerable to privacy breaches, what workstations are more vulnerable, and then you can actually do some different training initiatives or modifications to policies to actually cramp down from a larger perspective. So instead of looking at the top of the iceberg, you're actually looking at the iceberg overway and chipping it away in piece by piece. Does anyone want to guess what department in healthcare has the most privacy breaches that we've seen? What was it? Surgery? Plastic surgery? Nope. Let me ask another way. What do you think the role is? What type? Physician, nurse, admin, tech? Admin? That's what I thought. It's the doctor. Doctor's most likely to breach privacy. Guess which kind of doctor is the most likely to breach privacy? Nope. Nope. Who has the biggest ego? Cardiology. Cardiac surgeons, cardiologists, sons of bitches. Yes.
Yeah, how do you deal with so many different schemas and input data?
Yeah, interoperability.
Right.
Yeah, it's no joke. Because we have a data lake, the nice thing is, so we also don't have to deal with data interoperability, which is like medical records talking to each other. So there's all these fiefdoms in medical records where they don't want each other to talk to each other because they want to keep all the data to themselves. We don't have to interact with the medical record. We're only learning from the behaviors. We're only looking at the data and trying to absorb the behavior patterns. We're not writing back in or adding prescriptions or anything. So interoperability is not a challenge for us because we just add it all in the data lake and match the data sets. It's a great question, though.
Does this tool create new regulatory and compliance headaches for hospitals because now they have this technology that increases the amount of reporting they have to do to their regulators? Or you mentioned before, the institution decides how big the faucet, how big it wants to open the faucet in terms of number of hits it wants to accept. But if I'm a regulator, I might say, well, you just have to hire a whole lot more staff so you can process every hit.
Yeah, that's a really great question. So if I tried to start this company 5 years ago, it would not have been successful. The mentality back then was bury your head in the sand because every time we find out a privacy breach, we have to report it, we have to investigate, it costs time, it costs money, and maybe most of the time it's going to be a false positive anyway. Now that, in 2013 alone, we've had 90% of hospitals report a privacy breach, it's so pervasive, it's not a matter of if, it's just when. And so hospitals are just waiting for the big one to be caught. And so the really progressive hospital systems are turning around and saying, maybe I need to be a little more proactive about this because I don't want to wait to be, the MedStar or the Cedars-Sinai and have that big event. I want to actually find it before it happens. You bring up a really great question, though, which is, are you liable for using a tool that's unearthing more? And we are in a lot of discussions with regulators because this is setting a higher standard for privacy protection beyond what some hospitals have the capacity for. And what we do know is as long as a hospital compliance team is doing everything in their ability to monitor the most suspicious, the most risks, the most types of cases our system is detecting, then they're not going to be penalized for doing that because they're doing above and beyond what other systems are doing. So regulators, as bad of a rap they get, they understand that people are doing what they can, but we do believe we're at quite a bit of a forefront in terms of a lot of regulatory reform.
Have you thought of implementing this in other civil services like police or law enforcement where they also have sensitive information?
Yeah, does anyone know John Urschel? Yep, data scientist in the NFL. I've tried to talk to him about implementing this for the NFL because they have a lot of privacy breaches, but have not made a lot of headway there. There's a lot of applications. IRS actually has a tool very similar to this. Our system, unlike other systems that can just apply to everywhere, we're built around clinical workflows, so we are unique in that way. But we think a lot of the algorithms are extensible and applicable to other industries. As a startup, we got to be laser focused, though. Either or, JDBC or extract. Is that what you're asking? Yeah, so the question, just in case you didn't hear it, is are we sitting on top of the database or we create a new one? And the answer is we can do either or. We are not necessarily replicating because we're not using any proprietary data schemas. We're not using other people's proprietary data schemas. If we bring in a flat file, we're creating our own schema, or we're letting the analytics create their own schema. So there is some flexibility there, but we typically are not writing right on top of the databases. Any questions? Nope. All right, thanks so much, everyone.